Good morning, everybody, and good afternoon. My name is Sarah Hamilton. I'm the Interim Executive Director at FCAA, and I am pleased to welcome you this morning to the funder briefing responding to the monkeypox virus outbreak. Before we get started, I just wanted to give a huge thank you to our co-sponsors, funders for LGBTQ issues, as well as grant makers in health. Our combined outreach has resulted in more than 60 people registering for the webinar, which, given how quickly this came together, is pretty exciting. But more importantly, given the impact that this public health crisis is having on our communities that we all support, I think coming to this conversation and in a collaborative way is a very critical piece. So we're really grateful for your support and your time. A note on logistics. Let me advance these slides real quick. We do want to mention, we know when we first started talking about this webinar, we were saying that it would be a Zoom meeting, which would have allowed everybody to have their cameras and sound on and kind of participate in the conversation. Given the response, we did have to convert it to a webinar, which means that, as you can already tell, your cameras and sound are off. But we will when we get to the Q&A portion, we'll attempt to promote some folks to panelists if they want to speak. And I know I've talked to a couple of people on the line about that already. Otherwise, we really encourage you to use the Q&A and the chat function to kind of share questions and comments, and we'll make sure that that gets to the panelists when we get to that portion. We also want to note that the session is being recorded and will be available on our website after the fact. And we just ask for you to have some understanding and grace in that situation, especially if technology fails us when we get to that portion. Just keep your fingers crossed for me. So just a quick note a little bit about why we're all here today. I'm super excited to say that, not only do we have just a number of amazing kind of thought leaders with us today, a lot of them as individuals, but also as their organizations wear multiple hats in sort of the response. So while the goal today is to talk about sort of the funder response and which ways we can be kind of responding to monkeypox, we will be kind of coming to that discussion from a place of community perspective, as well as data, as well as policy. So we're really excited to have so much of that on the line today. So to kick off, I'm going to just share a little bit about show you a picture of who all, and you'll see them all in just a little bit. But, first, we're really excited to have the immense honor of having Greg Millett of AMFAR kind of kick us off with a landscape of what's happening in terms of both, what the monkeypox virus, what's happening, but also how people are responding. And then he's also going to share a little bit about sort of how AMFAR is responding as well. In response to that presentation, Carl Bologna of AIDS United, again, kind of bringing multiple hats of sort of funder, implementer, and advocate, are going to kind of lead a discussion in response to that presentation, but that's going to feature Jeffrey Crowley of the O'Neill Institute, as well as Daniel Driffin, who not only was the kind of co-founder of Thrive SS, but also currently serving as the monkeypox coordinator for INMAC. After that, we will invite some funders to the panel, including Darwin Thompson of Gilead Sciences and Mark Meacham of Eve Healthcare, who are going to kind of join us to talk a little bit about recent funding responses that their organizations have launched. We also have Victoria Kirby York of National Black Justice Coalition, who is partnering with Gilead in that response. And then finally, after all of that, we will have a Q&A portion, again, which we will encourage your questions via chat or the Q&A function, but if time, we'll be able to see if we can promote some folks to join that. So I am going to actually stop my share and hand over things to Greg. Greg, you can take it away.
Great, thank you. Good morning, good afternoon, and good evening, everybody. It's a pleasure to be here to discuss the monkeypox response and what we're seeing in terms of the US outbreak, as well as the response to the US outbreak. Before I start, I just wanted to talk a little bit about, what the contours of the outbreak is looking like right now worldwide. Worldwide, there are now about 55,000 reported cases of monkeypox since the beginning of the year. And in the United States, we are about 20,000 cases of monkeypox. When you take a look at that 55,000, though, there are only 500 cases that are taking place in those countries that have endemic monkeypox. So that's That's in Central and West African countries where historically we have seen some of these outbreaks. So this is by far the largest outbreak globally of monkeypox over the last 50 years since the virus was discovered. And you could also see here in the trajectory that the places in Europe where monkeypox first started, or at least noticed the outbreak, the United Kingdom as well as Spain, we're starting to see a decline in cases there as well as in other parts of Europe. Here in the United States, we're at the very beginning of a possible decline, but we really have just reached the height of the number of diagnoses that take place each week. And we're still trying to wait to see what the trajectory is actually going to be over the next couple of weeks. In terms of the government response, there has been a pretty rapid and vigorous response to the monkeypox pandemic in the US. With the first case that was reported on May 18th, and then soon after on June 10th, CDC documented the first cases of community spread. So it was spreading beyond some of the main partners or those individuals who traveled to Europe and came back with monkeypox. And then in June 23rd, we saw that New York City launched the first vaccine clinic in the United States to address monkeypox. We also saw that by June 28th, that HHS released about 56,000 doses of monkeypox. That was the first release of many releases of monkeypox doses. Also, by June 28th, CDC recommended a vaccine for gay and bisexual men at high risk for monkeypox for all gay and bisexual men. By July 1st, we saw that HHS ordered a huge number, 2.5 million additional doses of Jynneos vaccine for monkeypox. And by July 13th, HHS procured some additional vaccine, realizing that the scope of the response is going to be fairly large. And then by August 2nd, the White House named the monkeypox coordinators, Dr. Fenton, as well as Dr. Deskalakis. And August 4th, HHS declared a public health emergency in the US for monkeypox. Now, I worked with Jeff Crowley and his team in pulling together several policy documents for the monkeypox outbreak and trying to think about how we might want to concretize and think about this outbreak and some of the steps that we might want to have moving forward. One of the things that we suggested was that we should have moved to a one-dose vaccine fairly early because we know that we didn't have enough vaccine that was available. We also suggested that there be a greater community response in the outbreak and making sure that people who are seeking testing or vaccines are going to trusted sources for the vaccines as well as the testing. And we also thought about possibly using some additional money from HHS that could be transferred over to address the outbreak. And there were several of these things that we had proposed that the US government ultimately did do. But there's also more that the US government has done in terms of targeting Black prides and prides all across the United States and really trying to make sure that there's enough vaccine that was available. But unfortunately, we were a little late in terms of getting vaccines available and in responding to the outbreak. At the very beginning of the outbreak, there was only about 19 cases for about a month, from about June 1st through about 3 weeks or so into June. And then it went to about 173 cases. And when there was about 800 cases on July 8th, my colleagues and I at AmFAR thought, well, we need to try and figure out how much this is going to explode over the next month. We were curious to see how many cases of monkeypox there are going to be in the United States between July 8th and April 4th and August 4th, and August 4th being the date when there would be actually full doses of vaccines available. It's the 6-week period after which individuals in New York City began getting the dose of the vaccine. And what we found and postulated is that there's going to be 11,000 cases by that time. And there were a lot of people who were telling us that's far too much. There's no way we're going to jump from 800 to 11,000 cases by August 4th. And what actually happened is it did take place. We jumped to over 11,000 cases, and we were only off by a week by August 12th. And this really is showing how much there was exponential spread very rapidly in this outbreak in the United States. That over a month period, there was this 14-fold increase in the number of cases. And to put a finer point on it, US monkeypox cases were diagnosed on May 18th. There was only one case. By May 26th, 10. By June 16th, 100. By July 13th, 1,000. By July 29th, 5,000. August 10th, 10,000. And in less than a month, we're at 20,000 cases. So this is really showing how quickly the outbreak overtook us in the US and how unprepared we were to really address this beforehand. In terms of characteristics of the outbreak, many of you know, and you've already seen in the media, that most of the individuals, the overwhelming majority of the individuals who are diagnosed are male and gay and bisexual men. There are a few cases that we have seen diagnosed among transgender individuals as well as women, but not the majority of the cases. The substantial proportion as well is among individuals who are younger, from 21 to about 45 years old, where we're seeing most of the diagnoses that are taking place. The other thing that's different about this outbreak from previous outbreaks in endemic countries in Central and Western Africa is that the symptoms are not always noticeable. I'm sure many of you have been bombarded by images of people who have pustules and lesions all over their bodies, but that's actually not the norm in this outbreak. What's actually happening is things that are just not noticeable. People are seeing these small bumps that they might have in their mouths, small bumps that almost look like acne on their forehead, or even on their wrist, things that are not even larger than a mosquito bite, where a lot of people don't necessarily realize that this is monkeypox that they have, and they can unwaringly pass it on to their sexual partners. So this is something that's very different than what we've seen in Central and Western African countries in terms of monkeypox. And it really highlights the fact that this is a mutated virus that is somewhat different than the traditional virus that we've seen. The other thing that we're seeing as well is that this outbreak is heavily affecting HIV positive MSM. This is something that we've been seeing in Europe. We've been seeing it here in the United States as well. And when you take a look across studies, World Health Organization estimates that about 41% of diagnoses globally have been among HIV positive MSM. New England Journal of Medicine had a really nice study across European countries of the outbreak for monkeypox. And again, 41% were among HIV positive men. The Lancet had a nice study of the outbreak that took place in Spain, where 40% of those who were diagnosed were HIV positive. European CDC, as of last week, says that about 38% of diagnoses have been among HIV positive MSM. And here in the United States, 41% of monkeypox diagnoses have been among HIV positive MSM. But the one thing that's really clear that when you take a look among these diagnoses and the early data that are available is that we're actually not seeing a lot of differences in terms of clinical manifestations between HIV negative or HIV positive MSM in terms of this outbreak with where the lesions are placed, how many lesions people have, or even the severity of the disease. And when we also look at vaccines, we're also not seeing very much difference, at least in preliminary data, for vaccine efficacy between HIV positive and negative MSM. Both are about 30% protective for the vaccine, 7 to 14 days after the first shot of the vaccine. HIV positive men are slightly less protective, about a month after the first dose of the vaccine as compared to HIV negative MSM. But actually, after 14 days after the second shot of the dose, you really see no differences in the amount of protection against monkeypox virus compared to HIV positive or negative MSM. The problem, though, is that all these studies that we're seeing in terms of the vaccine as well as the outcomes are all among HIV positive MSM who are undiagnosed, or rather HIV positive MSM who have very low viral load. These are all people who have controlled HIV disease. So we're not seeing a lot of information among individuals who are undiagnosed with HIV or who have HIV for a long time, where I'm very sure we're going to see outcomes that are not as good as these outcomes that we're seeing in many of these studies. The other thing that we're seeing as well are differences by race and ethnicity. At the very beginning of the epidemic, we saw that to about mid-July or so, that about 50% of the cases were among Black or Latino MSM. So we saw these racial and ethnic differences crop up very quickly. And unfortunately, it's really transformed to be a primarily Black and Latino MSM disease over a period of time. These are data from CDC, and you can see from the green bars and the purple bars, with the purple representing Black MSM and green Latino MSM, that over time, that those bars have just grown exponentially, where now Black and Latino MSM are are, by and large, the greatest number of cases of monkeypox that are being diagnosed in the United States. And that's something that mirrors something that we see with HIV, with COVID-19, and unfortunately with other diseases because of the social determinants of health and really the stubbornness in our country in actually dealing with those social determinants. We're also seeing the same thing in terms of availability of the vaccine, where you take a look at Black and Latino MSM, even though they're more likely to be diagnosed with monkeypox cases, you can see in the orange that they're far less likely to have access to the vaccine or to be vaccinated with the first dose as compared to white MSM, who are less likely to be diagnosed with monkeypox. The other dynamic that we're seeing as well nationally that is somewhat concerning is that many people are not coming for their second dose of the vaccine. You need 2 doses of the Jynneos vaccine to be protected, fully protected against monkeypox. And the CDC director announced that as of August 23rd, with 200,000 doses of vaccine given, that 97% were for the first dose and that few people were coming back for the second dose. And this is something, of course, that could be concerning because it allows the virus to mutate. It also allows this outbreak to go on longer if people are not returning for their second dose. Another thing that we're seeing as well that unfortunately is a hallmark of a lot of outbreaks and infectious disease outbreaks that we've seen from HIV to Ebola to COVID-19 is blaming the victim and stigma. There's been a lot of stigma that's been leveled at the gay community. Here in Washington, D.C., there was an anti-gay attack that took place actually just blocks away from my house where a couple of gay men were beaten up. We've seen that lab techs at major labs, Quest Diagnostics, and other labs refused to actually test people's blood because they were afraid of monkeypox patients and stigma against monkeypox patients, which shouldn't exist because these lab workers should be using universal precautions. But all of this is stigma and homophobia that's being leveled at the LGBT community. However, we're also seeing a lot of resilience in the face of stigma and in the face of this outbreak among gay and bisexual men. CDC released data from an online survey that found that about 48% of gay and bisexual men have reduced their number of sex partners during the monkeypox outbreak. 50% have reduced one-time sexual partners or anonymous partners or hookups during the outbreak. And 50% also reported reducing sex with partners that they met online on any of the dating apps, such as Grindr or Scruff or any of the other apps. So you see that the community is responding favorably in a way to actually reduce monkeypox within the US. And we're also seeing a lot of gay men fighting the stigma by talking openly about their monkeypox diagnosis and going onto TikTok, going onto Facebook, going onto Twitter and other online sources and talking about their monkeypox diagnosis, or proudly saying that, you know, they've been fully vaccinated for monkeypox and also have their newest and latest COVID-19 vaccine as well as a flu shot. So many men are really changing the narrative around monkeypox, and a lot of this is empowering, and a lot of this actually reminds me of the way that men were empowering around Truvada when Truvada was first released, and then back in 2014 or so, there was a lot of blowback by healthcare officials as well as some others in the gay community that people who use Truvada are too sexually permissive, and men went online and they were showing their Truvada pills and saying that, you know, proudly saying that they're taking this pill. So a lot of that we saw in 2014, that spirit and that resilience and fighting in the face of stigma is taking place right now with monkeypox. One thing, though, that we also need to know is how are men responding to this outbreak? And we're seeing a lot of online surveys that are taking place. One that Coletso Mokafane is doing in New York City. There's another one here in Washington, D.C. that researchers are doing an online survey to really just try and understand where men are. How is stigma affecting whether or not they're getting vaccinated? How is it affecting people within their friendship networks? How are they changing some of their behaviors, et cetera, just to try and understand what the dynamics and contours are of this outbreak. And in terms of funders and some of the things that all of us could be doing to help address this outbreak, I could talk about really briefly what we've been doing in my office. The first is, you know, some of the things that I shared earlier, that we're working with O'Neill Institute and Jeff Crowley and his group in releasing policy briefs and information on some of the policy changes that could be done to help curb the outbreak, to help the government with the outbreak. Also with Jeff Crowley, as well as with researchers at George Washington University, we've been publishing several research commentaries on the outbreak, both globally as well as domestically, and some of the steps that should be taken that we've been putting into research journals. We've also been funding research studies. So I showed this study that Calypso Mokafane is doing in New York City, which is really just trying to understand the extent of the outbreak among men who have sex with men in New York City. We were the first organization to provide seed funding for that research. We're also funding another research study in New York City as well with Columbia. And then the last way that we were really just trying to address the outbreak or be a part of the outbreak as a funder was actually doing the forecasting models to project how this outbreak was going to move forward in the United States. And those are the data that I showed you where we projected that it was going to be as much as 11,000 cases in a very short period of time to try and raise the alarm among policymakers as well as public health officials that we needed to move quickly to address the outbreak. And with that, I wanted to thank again the funders concerned about AIDS and others for the opportunity to speak this morning, and I'm looking forward to a vibrant discussion. Thank you.
Well, thank you for that information, Greg. That was really enlightening and very thorough. I want to introduce some of our other panelists who are going to provide responses, but Greg, of course, you're welcome to join in and provide responses to questions that we have. So I'm Carl Bologna. I'm Vice President, Chief Advocacy Officer with AIDS United. Really pleased to be with you all this morning. We're also joined by Jeff Crowley, Distinguished Scholar and Director of Infectious Disease Initiative at the O'Neill Institute at Georgetown. Daniel Driffin is currently serving as INMEC's Monkeypox Response Coordinator. And of course, we've met Greg, who's Vice President Director of Policy with AMFAR. We're also joined by a esteemed panel of funders, Darwin Thompson, the Associate Director of Corporate Giving, where he managed to get domestic HIV grant making, Victoria Kirby York, the Deputy Executive Director of the National Black Justice Coalition, and Mark Meacham, Head of U.S. External Affairs at ViiV Healthcare. Mark Meacham directs all U.S. external public affairs activities, including ViiV's Healthcare Positive Action Southern Initiative, Positive Action for Women, among other things. Again, Greg, really enlightening presentation. It's frightening and amazing how quickly this virus has escalated globally and in the U.S. I'm wondering if folks have any comments around Greg's presentation. What resonated with you all from the information that we've learned communities are experiencing related to monkeypox?
So maybe I could jump in. Just a couple of quick observations. I mean, I think one, that Greg had pointed out the government did do a lot, but they didn't do enough. And I think there's a risk that we get so focused on it, just still be mad that we don't have enough vaccine. There's things I still think we need to see more of in the immediate period, and that's funding communities and community-based organizations. They quickly scaled up their testing capacity, but I still don't know how many people are actually being tested. I don't know how much we've improved access to TPOXX. But I think this just exposes, again, as did COVID, we really need some longer-term structural changes that you can't really do in a crisis. But we need to reinvent public health. I hear a lot about how we can't do certain things because of our system of federalism. I'm not really sure that that's right. And but you know, we expect like CDC or the federal government to be able to turn on a dime and mobilize the country. We're not set up that way. Every time there's an emergent infection, as with monkeypox, they have to negotiate new data use agreements to get the data from health departments. We just got to get over those things. We also need to have available resources when an emergency is declared that we can just deploy right away. And those are longer term things. Also, like we've been saying, oh, you need to fund CBOs, you need to fund CBOs. Health departments and everybody should have a stable of people, and whatever a new crisis comes up, they're just ready to go with existing partnerships. And so I think there's a lot we need to do in the immediate future, but I also want us to focus on some of the longer term structural changes.
Yeah, I think for me, the initial thoughts is definitely just increasing awareness and more education. I think this is the first time I'm hearing, Greg, especially around the mutations of the virus and the onset of symptoms or just looking like mosquito bites. You know, when we think about the majority of Black people live in the Deep South and the majority of people living with HIV live in that same geographic, you know, mosquitoes are everyday encounters, you know. So if you're walking around scratching your arm thinking it's a mosquito bite, but it's actually monkeypox, like what are the implications for there? So I definitely think that's one time. And I'm, you know, ready to share that. I think very similar to what Jeff was just saying about funding, ensuring funding is getting to those trusted organizations that Black and brown men use every day of the week, and not necessarily the organizations that have been always funded through our state and local health departments that may not be synonymous with those communities at greatest risk.
I had to be on mute. Apologies. Thanks for that, Daniel. Really helpful response. I'm wondering, what else are you all hearing from the folks that you are talking to in community about what's needed? What is lacking? We know that the government had a lag in getting out doses to priority populations. And when they were able to, it wasn't necessarily adequate number of doses. What are communities facing right now? Has the government caught up? What is the next step?
I'm not sure how to answer that. So, I think we're frustrated there wasn't adequate vaccine. I know when they talked about moving to the intradermal dosing, there was a lot of concern, at least in Washington, D.C. I know some of the primary concerns is like people that are susceptible to keloids or keloid scarring. If you indicate that, they'll give you the regular dose or regular administration. I hope those kinds of things are happening elsewhere. I think to a large extent, this move to intradermal, which is really freeing up a lot more vaccines, has gone better than many of us expected. But I also think that there was so many concerns raised about this move that we may have scared people off. And I was especially troubled when Greg talks about the people not coming back for the second dose. A lot of people got their first dose and then they're told their second one is this intradermal that people are raising questions about. So I think we need to think about how we're, inviting people in and both saying if you're susceptible to keloids, that's not your only option, but also just tell people this approach works. So it's, again, this is a stopgap, but I think that's an important thing. The other thing I would just say is all of us, when we try to get action, we talk about what the gaps are and things that aren't happening. And one thing I appreciate with Greg is our community stepping up. I look at many of you on this, I'm proud, but just proud to see the community response. So we should also celebrate that and use that as motivation for what we've done with or without the government.
Hi, I just think it's a great question. I know this is jumping in a little bit ahead of my section, but the question was just so good. I wanted to respond. One of the things I think is important is, and again, my name is Victoria Kirby York with the National Black Justice Coalition, is what just kind of played out in the conversation around description-driven explanations, like literally describing some of the symptoms as a mosquito bite. Even when I think about terms like keloids, I have a number of relatives who live with keloids and have no idea that term exists, right? It's just something that happens to their skin, right? And so thinking about how we talk to the general public at that 8th grade education level about some of these health related things is so important. So whether it's using, pictures of diverse skin types and colors, or, getting really rich in imagery in the descriptions, and using terms like keloids, but then describing what that means, right? Like raised skin, etc. And thinking about the various kinds of locations of care that are going to be more pertinent, particularly in Black communities in the South. Yes, community health centers, but also urgent care centers, walk-in clinics, places that don't require appointments. So you can kind of make the choice to go in and out based off of how your day unfolds, especially if you are living on a budget with not as many resources to get around. Those things become incredibly important. So just wanted to jump in really quick on some of the threads that I saw kind of emerge in just that last segment of conversation, because I think it's so important for people to really take some of those kernels home.
I think the other, I'm so sorry, Carl. I think the other thing, I would definitely lift up is I don't feel the awareness for people living with HIV is there. If more than 40% across our nation and, other countries are truly living with HIV, I don't think our partners, across those places where people living with HIV receive their medical care is lifting this awareness or lifting this conversation up at the level that we need it right now.
Thanks, Daniel. Victoria, I appreciate you joining the conversation. I actually think it's probably a natural point to just merge the conversation. So I want to invite our funders on the line to join in if you have responses to what's currently been said, but also would love to hear about what your organization's work has been in regards to responding to the monkeypox virus, and what are some opportunities for us to engage community better with, to be more closely aligned.
Yeah, I mean, I think that's a really good question. I mean, I lift up what everyone else has already said. I think from a Gilead Science, perspective, right? We heard loud and clear from the community as early as May that this was going to be a significant issue for our community partners, right? And I think it was magnified at IAS, specifically with, low vaccines available in the United States. So a number of people, being able to take advantage of vaccines in Canada and versus in the US. And so we really wanted to figure out what was the best response to addressing this thing, is that we are, this isn't one of our therapeutic areas, but we understand the impact that it has on people who are living with HIV or at risk for HIV. And so I'm excited that Victoria's here. And so we really looked at it from like this multi-pronged approach, right? The first is to really think about how do we address misinformation, because we understood that a lot of organizations, community partners, in a rush to get out information, which we think was important to really, raise the alarm around, how this impact community, was not sharing the same information that might have been funneled down from CDC or from their local health department. So really work together to identify national partners who had access to media, and we also had ties to community, to really present one set of information, one set of data that was scientifically backed, but also could use influencers, could have a high social media impact, those types of things. And then we also understood that there was still a need to advocate at the federal level, more importantly at the White House level. So partnering with NMAC to really think about what was a policy response to this, and how do we, to Jeff's point, get more resources to community, get more access to vaccines, more access to medication. And so that was a sort of approach that we looked at. But then also there's a third way where we also said we got to support these community-based organizations who are just getting out of COVID, who are just who are trying to get back into HIV, and now there's this third sort of pandemic that has hit their doorsteps. And so we provided resources, sort of general operating resources to organizations that we currently fund, up to $50,000 to really look at personal protective equipment, temporary staffing, because what we also understand is that some of the community-based workers, they also live and work in the environments that they're trying to serve. And so there have been a number of times, or a number of partners that we talked to, where their staff have been diagnosed with monkeypox and they were out 4 weeks. So temporary staffing, access to information. We see a number of partners doing town hall meetings, really galvanizing their communities. And so we looked at those approaches to really think about how do we address it in a systematic way, but it's also very thoughtful of community, but also looking at a one voice sort of response.
A couple of things I'd add to what Darwin has said. I mean, I think first and foremost is that we have to remember and see that we were seeing real time that this was about race. So the same way we weren't surprised to see that COVID had the disproportionate impact on Black and Latino communities from the beginning. I think this group of people who were in various text chains and email chains and talking about on a daily basis saw that this was about race. I think the second thing to underscore is about where are the people who are actually serving these communities. And I think, again, to pick up the point that Jeff made, this was about the community-based organizations that were on the ground and were the first to try to respond, often with a lack of information, even when they were reaching out, I say, to some of the health departments, there was a lack of useful information about how to do the response. But that being said, the community-based organizations were the first one out. So I think that's one of the most important things about this work we're doing to funding the groups, is the support of those organizations that are on the front line. I think an additional thing to underline is that they are overloaded. These groups, just as they picked up extra work with COVID and have continued to do that, they picked up an extra workload. They had staff quitting, I think, and not just staff affected by monkeypox, but also staff who quit as a result of, because they were affected as well as their clients. I think that increased foot traffic, again, as with COVID, has had similar kind of needs. So increased needs for staff time, increased needs for cleaning and disinfection of spaces, PPE, all of these kind of core things that, once again, there's an extreme immediate need. And so I think those are some of the key things. I think one last thing I'd like to say is, I wonder, as we look at this work, if there's not the opportunity sometimes to not recreate the wheel. So we see that there's some places that have been ahead of the work. They're ahead of the work in terms of getting out word on social media, getting out the word in the right places, at prides, at bathhouses, at bars, etc. And you see in some jurisdictions that might be further behind, or places they're developing their own. And I know that there's, there was one of us who used to say a long time ago, if you've seen one epidemic, you've seen one epidemic. But I don't know if we need 300 social media programs or different approaches, if there isn't some room for us to not recreate the wheels. So those are just a few things I'd like to lift up.
Mark, in speaking of not recreating the wheel, I think your organizations have tried to be innovative to provide additional flexibility to your grantees to respond to monkeypox. You certainly did that with COVID-19. Are there any particular mechanisms that you will have created ease around that you want to encourage other funders to pursue to make sure that CBOs are able to respond quickly?
Well, I think one key thing is speed. That's the element I think that we've all mentioned. And so the approach that Darwin mentioned, and then that we've taken as well, of, we're working from an existing base of people that we know that are in the community. We know they have the reach. We've been there. We've been in their locations and seen that. So I think there's that speed. There's that need, that there's a mapping need, I think, because I think this is a broader discussion we've had. But there's always been this question of resources and how long it takes for resources to trickle down to the people and the places who are on the front lines. And that's just something that we've got to find a way to disrupt, because the end game is that the resources don't get to where they need to be fast enough. So I say those are the 2 or 3 key things.
Yeah, and Carl, can I jump in here? I think the other thing that I would add is that at the end of the day, it's, to a resource perspective, it takes time to submit a request for funding, even if it's for emergency funding, right? So I think the other strategy that we use with partners who we just don't have the capacity to apply for these resources is, can we reallocate current grant funding to support this outbreak? And so, I mean, I think that's the other consideration as well, is if their current grants that you already have is to be able to, move with the quickness to say, you can take 50,000, 75, 100,000 of this grant and put it towards this response, because we understand you just don't have the capacity to submit us an application. So I think that's another tactic that funders can use as well.
And just to speak as a Gilead grantee, one of the things that we appreciated most was the unrestricted nature of the funds and the awareness that was presented from the very beginning, that the work that we were already doing around Mpox was pulling from some of our existing programs that we had planned, and the understanding that this would allow us to be able to continue to do the work that we already, had been building towards ahead of this outbreak, and also be able to do what we know was necessary to engage Black, LGBTQ+, and same gender loving folks, which is to make sure that we were front and center in educating our people about what was happening with this outbreak. In particular, because one of our earliest lessons was that although the statistic has been around for a while that Black members of the LGBTQ plus and same gender loving community don't live in neighborhoods like Wilton Manors and Chelsea. The real life implications of that seem to be missing some of our public health officials. That if you're trying to reach the LGBT community, like all of us, you can't just send vaccines to the neighborhoods. If you're going to reach Black and brown people, the resources have to go to Black and brown communities. And so that meant hitting inner city clinics. That meant having a plan or sharing best practices from some of the LGBT health centers that are in other parts of town, with emergency room and trauma one hospitals where, you know, that's the doctor of choice for folks who are uninsured in some of these communities. They get sick, go to the emergency room. And so kind of taking those statistics and problem solving from there and talking to people about their real life lived experiences as a part of addressing it was something that we saw was really important. Thankfully, we also had a pre-existing relationship with our HIV work with the CDC, so we were able to get good, you know, credible information out there early. But being a part of this collaborative has also allowed all of our colleague organizations to come together and meet with White House leadership together to ask questions and to learn from each other in the space. NMAC folks would ask questions that may not have occurred to me. I might have asked questions that may not have occurred to GLAD or HRC or NCLR. And that, you know, that also allowed us to sharpen each other, to learn from each other, and to also talk about what was working, what's not working, and what we needed government to do better. So for instance, we were able to talk about the importance and to applaud their advocacy at Black Pride, but to also say, if possible, let's get you connected to the organizers to also look at just the geographical data and you know, to protect confidentiality and look to do forward tracing, right? So if we can just look at where folks are coming from and see where we have a larger imprint of folks going following Atlanta Black Pride as an example, or the Black Prides coming up in New Orleans and Oakland, you can begin to see, well, where are folks going to be going in mass? And to also make sure that there are vaccines in those communities ahead of what might become another outbreak. So those are things where we're able to talk about these things together, and then also make sure it's not just one of our organizations pushing forward different solutions, but that we're all able to create an echo chamber as well. And we're able to do that because of, you know, the collaborative that Gilead has created.
I just want to mention one thing that, you know, Daniel took from my presentation that I really think that we shouldn't lose sight of, and that's the degree to which HIV positive individuals are implicated to such a high proportion within this outbreak, both domestically and globally. And you know, I think the response there is an immediate response, but there's also a downward effects long-term response that we're going to have to keep in mind. In terms of the immediate response, it's the fact that in the United States, you know, the HIV pandemic is primarily among Black and brown individuals. And among those of us living with HIV, most of us are not virally suppressed. And those data that I was showing during the presentation is showing, you know, data among HIV positive individuals who are virally suppressed where there were very few clinical manifestations if they did get monkeypox, and if they got the vaccine, that you had a really good response to the vaccine. We're probably not going to see that for Black and brown communities because we are less likely to be virally suppressed. So we have to be very clear about that. We need to get some good communications out there. We need to make sure that people get tested as soon as possible. And if they're tested, to make sure that they get into care as soon as possible. We also need to make sure that as many people who are HIV positive are getting vaccinated. And then I think the downstream effects, which are some of the things that we need to take a look at, is that right now, we're living in the midst of a viral storm. We are being buffeted by not only HIV, but by STIs, by COVID-19, by monkeypox. And the thing is that a lot of these diseases have a lot of the same clinical chronic health condition outcomes that's going to be difficult for particularly communities living with HIV. So HIV and being on meds, COVID-19, and just at least even having mild COVID-19, and having monkeypox are each associated with heart disease and chronic health conditions in terms of heart disease. What does this mean for people living with HIV who have had both? What does this look like in terms of care and in terms of some difficulties that they might have later in their lifetime? So, we have to be very clear that it's not just the immediate response that we have to do in terms of raising awareness and getting people to vaccines and getting people tested, as well as access to care. But there's these long-term consequences of having any of these conditions that unfortunately really reinforce one another and produce even poorer health outcomes for people living with HIV.
I wanted to pick up a couple of threads. I think one is around how the healthcare system, so I took out urgent cares, hospitals, et cetera, treat folks of color. I don't know any simpler way to put it. And I think the reality is, particularly if one is a male of color, is that if you don't have trauma, if you don't have a bullet wound or a knife wound, there's nothing wrong with you. And we've seen this. And so what that looks like is or what that looks like is you're told to go elsewhere. So, in the DMV area, there are people who go to the ER with an AIDS diagnosis, with AIDS, and are told you need to go to the clinic. So they're not told what that means. They're not started on, their OIs aren't treated. They're not started on antiretrovirals. They're told you need to go to the clinic. And I think similarly, that sort of, what's the word I'm looking for? Lack of exploration and analysis and just engagement that happens when we are in these kind of situations is something that we just have to call out, because there are many, many stories of the folks that went with monkeypox or COVID symptoms and had similar kinds of responses from the healthcare system. So that's one thing I think we really can't ignore. I think the other thing is, and I hate to use this word, is that when we have these situations, is that how do we turn this into more of a discussion and more of a chance to raise the awareness around health in our communities, as opposed to just reaction to an emergency. And I think that's, back to the days of testing when it was just you're good, when you got a negative test result, and then that was it. There wasn't to talk about PrEP, et cetera, that could have been there in many cases. So I think, as Greg was saying, how is it that we talk with people about, let's look at your entire health as opposed to just get you a monkeypox vaccine? And so those are the two things I wanted to lift up.
Thanks much. Well, Daniel, so we probably need another 60 minutes, but we only have 11 minutes left. I want to encourage us to be really interactive. We have a really great chat going. So I kind of wanted to, if folks want to perhaps respond in the chat, I'm curious about folks' ideas related to what infrastructure we need to deal with the next outbreak. I think Jeff mentioned our preparedness, what we thought the CDC could do in terms of preparedness after COVID-19. There was supposed to be increased flexibility, but we're not seeing them able to turn on a dime the way we would like to see them. But we do have some folks from Prep for All on, and we have a question directly related to them. It says that Julie Patterson says Prep for All has raised the alarm about access to TPOXX for Black and Brown communities. What can we do as funders to build demand for TPOXX and improve access through funding community organizations and our community providers? If any folks want to respond to this, if our Prep for All folks are able to respond, but also opening this up to the larger chat.
I will say that we've gone for where the fire, to try and put out the fire, if you will. So our initial focus has been, again, that on the grounds approach. I think the advocacy piece is something that we have to find ways to support as well. And I think that we also just have to factor in, I know we're in our last minutes, but that we're under our communities, and this movement, I would say, is under attack in many formulations. So the news just broke that in the Texas case around PrEP provision, they just ruled an astonishing and demoralizing ruling that it violates religious freedom for certain organizations. So there's so I think that more than ever we need to fight on multiple fronts, and I think I think there's an increasing need for even more coordination and cooperation there. I'll just say that.
Just a note from FCAA that I've enabled a couple of mics for Prep for All if they want to come on and join the conversation.
Yes,
Yeah, so I think, hi, this is James Carlson. I think both me and Kenyon are going to speak a little bit about sort of on both TPOXX and vaccines and diagnostics, because just going to the TPOXX stuff, we still have a major policy barrier to getting to Covermat accessibly access, which is that we have this expanded access individual investigational new drug application process that is needed to access the drug. And if you actually talk to the FDA, they will basically admit to you there is no scientific or regulatory necessity for that EA-IND process. And that EA-IND process we know actually right now is manufacturing structural inequities to TPOXX, because it requires basically that physicians be highly experienced in either prescribing through an IND or basically to be affiliated with an academic medical center that can run through an IRB. And given that this is a very safe FDA-approved drug, that just is not necessary right now. And Kenyon can give a little bit more of the perspective of what that looks like from a lot of communities and from his home state of Ohio. But I wanted to say that this problem we're seeing across the continuum of biomedical countermeasures for monkeypox. Right, every single vaccine that has gone into arms today was ready before that first case was diagnosed in Massachusetts on May 17th. And we know that had we actually more rapidly deployed those vaccines equitably, we probably would have stopped this outbreak months ago. And I think one of the things that we need to be thinking about as funders is how do we support policy advocates to actually be pushing the federal government to rapidly deploy those tools that are ready to go in an equitable way so we can stop an outbreak before it spirals out of control. And I think we've had a lot of success in getting that done. But just to be frank, I mean, we've gotten the FDA to move up the inspection. We got those doses to be shipped when we started pointing this out in early June, but it was kind of not fast enough, right? We allowed this outbreak to spiral out of control, and we're still allowing it to spiral out of control and to be inequitable, and for the response to be completely inequitable. And that was a choice that our government made. So I want to pass it over to Kenyon. I know you're, Kenyon, are you unmuted right now?
Yeah, I'm unmuted. Yeah, so I'll just say specifically, so in addition to the things that James sort of named at Prep for All that we sort of started working on, we started doing work in June at the federal level, because I'm here I moved back to my hometown, Cleveland, Ohio 2 years ago, and kind of seeing how the response here from the health department was pretty terrible, right? From the state health department. And I published 2 op-eds in the state, a publication called Ohio Capital Journal, both of which that got reprinted across the state, that in some ways became the thing that pushed the state health department to actually roll out, as they were getting doses of vaccine, but they were just sitting on them and not giving them to Cuyahoga County, which is Cleveland or Columbus or to Cincinnati to implement. And so there's, one of the issues obviously is around, just obviously the sort of racial and equity issues that, have been raised on this panel. But, when you're working in, kind of context where, the state's, apparatus is conservative. And we were sort of directly told by the people at the Ohio Department of Health that, well, how the, kind of state house and the governor is conservative, and we essentially can't do anything. So they were asking community-based organizations with no funding to actually roll out education programs, testing, or get people pointed to where testing was, and then much less vaccine and then TPOXX access. And it took, some pushing from, myself, and then from a couple of other, and frankly, led by Black gay men here in the state, Darius Houston at Central Wellness Outreach, and Dwayne Stewart at Equitas Health, to get them to actually respond. And so, a lot of what the sort of national press kind of took on was what was happening in some of the bigger cities, DC, Atlanta, New York, LA, but folks in the middle of the country, even in a Medicaid expansion state like Ohio, had to do a lot of heavy lifting in order to kind of get, so I agree with both funding community-based organizations to do that work, but also to fund them to actually do the advocacy and activism, and also to be, I think, a lot of the kind of work to understand the sort of technical expertise that you need as an activist to do some of this work like effectively. So as I often tell people, half of activism is knowing who to be mad at and really being able to sort of push, where you can in order to kind of impact change.
Thanks, Kenyon. I wholeheartedly agree. I really appreciate that perspective. I do want to create an opportunity. We have Remco Lewin to provide the EU perspective so we can learn from our friends across the pond.
Yeah, thanks for inviting me, and I really enjoyed the discussion over the last hour. I actually want to raise 2 points, which I think are quite important. A lot of the discussion that I heard over the last 55 minutes was very US centered. And, I recognize that from my own country and my own organization, where we initially dived a lot into the national response. But, we feel that it is really important to recognize that this is not only an epidemic happening in the United States and Europe, it's a global pandemic. And when we talk to the community-based organizations that we work with in Africa, we really feel that, they feel left behind. They don't have access to vaccines, they don't have access to the right information, don't have the funds for community outreach. And I really think it's important that, first of all, we recognize that these community-based organizations in forefront in Africa and Latin America need to be supported for their work. Second, I think it's very important that we have to recognize that these countries, a lot of these countries were what we now call the traditionally or the previously endemic countries. And if we really want to do something about this pandemic for the long term, we need to do something in those countries as well. We do see a decline in monkeypox cases here in Europe. It's actually quite striking over the last couple of weeks. We don't know for certain what the reason is for that, but even if the epidemic dies out, we know there will be new introductions. So for the long term, we need to have attention for endemic countries. The second thing that I would like to say, and it's a bit I would say in line with the comment from Prep for All about the sort of lack of response from US agencies. I think if we look at the international agencies that should live up to their mission and their promise, and I'm now looking at the WHO, at Gavi, at UNICEF, at HERA, they have not been very reactive. There's nobody that's really taking leadership to actually boost the development of an easy-to-use diagnostic of equitable access to TPOXX and to vaccine manufacturing capacity, which is currently at still a critical skill, and where we really need to have more capacity developed over the long term. So I see we're close to with the hour, but I really would like to see some comments from the panel on the international outreach. Thank you.
No, absolutely. I agree completely. As a matter of fact, we released a couple of documents, saying, including in BMJ and other places, that if we don't focus on the global pandemic or what's taking place globally in countries where this hasn't been endemic, that this is going to be an issue. What we're seeing and why we have this outbreak is because we have ignored outbreaks that have taken place in Central and Western Africa since 2000, essentially, with a lot of academics and researchers and people in ministries of health saying that, this is something that is becoming more frequent. This is something that's not just going to be localized to our areas. And these outbreaks have continued to grow in scope across Central and Western African countries, and we've ignored it. And it's the same issue that we have in terms of the vaccine inequities for COVID-19. You know, as long as we continue to have the vaccine inequities of COVID-19, where there are countries in the global south that don't have access to those vaccines, then we're going to continue to have different mutations of COVID as well. So we're not learning the lessons that we need to learn as a global community, that we need to address these infectious diseases everywhere and equally, and that the tools need to be available for everyone. So thank you for your comments. We definitely appreciate it and glad that you brought it up.
Thanks, Greg, and everyone. I feel like a major takeaway for me has been the need for strategic planning and communications. The federal government does not have the speed that we would like to see. I really appreciate the funders on this call creating flexibility in their funding approaches. And this is likely not the last epidemic that we're going to face. So thank you for continuing to include flexibility in your work. I know at Age United, we're striving to do the same. Thanks everyone for their perspectives, and it's been great speaking with you. I think Sarah has some closing comments.
I just want to echo all of that and thank you for your time and coming together. We know there's a lot that came through on the chat and the Q&A that we maybe didn't answer entirely, so we'll kind of go through that and see if there's anything else we need to kind of follow up on, or even that could serve as the next conversation that we have. So we just wanted to thank you for your time. Stay tuned to the space. We'll be sharing the recording and sort of other resources that were shared during this. And we know, as has already been said, that this is not the last time we are going to talk about this. So thank you again. Keep, if you have more questions, send them my way. Like, we'll do our best to kind of connect with our speakers. And that's it. So thank you for making time and space for this. And thank you for all that you're doing. Have a great day.
Thanks, everybody.
Thank you.